بسم الله الرحمن الرحيم والصلاة والسلام على خير الأنام سيدنا محمد وعلى آله وصحبه وسلم. We continue our lectures about the coronary artery disease in various parts. We speak about the approach of management, and we speak about the stable ischemic heart disease. Now we will speak about the more serious and progressive one, which is known as acute coronary syndrome. And as we discussed before, the acute coronary syndrome is a clinical spectrum which is lead to acute myocardial ischemia اللي هي progression of stable ischemic disease which can lead to myocardial ischemia. This could be a myocardial infarction per se or impending myocardial infarction. So it's not a myocardial infarction now, لكن soon will be a myocardial infarction. So both of them are serious, and we have to deal and to treat them as a serious condition. We have two main types of this acute coronary syndrome. One of them appear in ECG clearly as ST elevation, and we call them as ST elevation acute coronary syndrome أو بنسميها STEMI اللي هو ST elevation myocardial infarction. Here in ECG clearly we found that there is ST elevation with a myocardial infarction. And we have a type which is not appear as ST elevation, so it's a mild infarction, it still not appear as ST elevation, or it could be is just as unstable angina, يعني there is ischemia, high ischemia, but still there is no infarction. Also, we deal with them as a serious condition because it will progress to be ST elevation or a myocardial infarction. This is known as non-ST elevation acute coronary syndrome or NSTEMI اللي هي non ST elevation myocardial infarction. طبعا ديل عندنا منهم two types, one known as non-STEMI, وهنا we have a positive biomarkers troponin become positive, لكن there is no a clear ECG that indicate there is a myocardial infarction. In the other type is unstable angina. Well, unstable angina, there is no biomarkers, there is no ECG change, لكن there is a progression for stable ischemic heart disease. The patient becomes stable, and then there is a progression in frequency, intensity, and duration of the pain and symptoms, and clinically we regard this as ischemic disease. It could associated with ECG change, but not ST elevation clearly appear. These cases is differentiated based on investigation and not just based on clinical suspicion. We will start by how to manage the first one, which is a serious one, the STEMI, which is ST elevation myocardial infarction. وزي ما قلنا, this here we are confirmed there is a myocardial infarction and there is a complete block for the coronary arteries. And here we regard the time is muscle. We have to manage the main guidelines, the main goal of therapy is to treat the patient as soon as possible. Time is going, the muscle is going. And our main treatment is to revascularization of coronary artery to prevent the progression of the death of the cell. So we keep the cell alive, the remaining cell which is alive, we keep them alive. We have two main types to treat the patient with this problem اللي هو عندهم complete block for the coronary artery and ischemia. Firstly, we have PCI اللي هي percutaneous coronary intervention, And this is the preferred one whenever we can do it. If we have any patient coming to our casualty or emergency room with a, yes.
Keep them on the stick. And when I went to go get the pot, it turned out fine. Or not. So when I tried a second attempt, I put chocolate on the sticks before putting them in the stick. But no
Nora?
matter what, it still starts to soften out.
Nora? طيب. You have a question يا نورا ولا we continue؟
لا ويكونتينيو بالغلط دكتور.
تمام. طيب. قلنا if we have a patient with symptoms of MI and we confirm the diagnosis by ECG as STEMI patient, firstly we have for all patients to do something known as a code STEMI. And this is mean that they code blue زي كده means the emergency, and we have to consult the cardiologist immediately. We have to call the cardiologist, do the code STEMI, and the cardiologist should see the patient immediately to gain time. Like if we found the patient is coming and we have a facility to go into the PCI within 2 hours اللي هو 120 minutes. So the preferable way for the treatment of the patient is PCI. Directly we are going to the PCI, and immediately also we give the patient before even the PCI the antiplatelet therapy and anticoagulant, and we have to enter and to do the PCI within these 2 hours. It's preferable to be less than that, within 90 minutes, like in the maximum is 2 hours. Like if we found the patient cannot do the PCI within 2 hours, it's not capable facility within these 2 hours, and the patient is coming early, yani after the patient develops the symptoms, the patient is coming before 12 hours. Yani the patient starts the symptoms and coming to the hospital before 12 hours after the symptoms. So here, and we can to do PCI for the patient. So here we can يعني think about doing a fibrinolytics drugs or fibrinolysis for the patient, but with also some caution. Also زي ما قلنا for all patients we have to do a code blue, code STEMI, and we have immediate consultation for cardiac physician. And then if there is no contraindication for this patient for fibrinolysis, and we will know the absolute contraindication for the fibrinolysis, we can do a fibrinolysis for the patient for the treatment, and then we can transfer the patient to PCI. We gain more time, the muscle will be more safe, and we can do PCI later for this patient. Also, for all patients, we will give antiplatelet and anticoagulant whenever, whatever the patient using the PCI or using the fibrinolysis drugs. طيب the revascularization strategy زي ما قلنا the primary, the preferred one إنه to do the patient PCI from the start, from the first medical contact for the patient and confirm the diagnosis till to do the surgery for the patient. It has to be less or equal to 90 minutes, لكن up to 120 minutes is acceptable. The indication, the patient with STEMI, يعني ST elevation appear in the 2 leads of the ECG, or in some cases the STEMI we have which is called STEMI equivalent. There is no ST elevation because there is other heart problem which is changing ECG, so it is not a clear ST elevation, لكن it is equivalent. We regard that as equivalent for the STEMI. This is commonly in a patient with bundle branch proc إذا كانت left or light bundle block عادة ما بيظهر لنا شنو we cannot define the ST elevation. So in this patient, if they are a highly suspicion for ischemia, or we have which is known as Garbosa criteria in Italian, and in English بيسموها Escarbosa criteria. If it is positive, I highly suspect it for the patient has STEMI, so we are going to primary PCI. Primary PCI means from the start we do the patient a PCI. We don't do a revascularization through the fibrinolysis medication. Directly we going to the PCI. So this is primary. If we do a fibrinolysis through a medication and then we transfer that patient for the PCI center, so the PCI which is known as a secondary PCI اللي هي known as a PCI after thrombolysis or fibrinolysis, and it could be done after a successful or failed fibrinolysis, and PCI is indicated even if the thrombolysis is weak. يعني حتى لو البيشنت عملنا له thrombolysis and it's weak كان حصل revascularization للcoronary artery, we have to go into the PCI and to put a stent for the patient لأنه recurrence بيكون highly suspected and the revascularization is not perfect like the PCI. So we have to go to the PCI. طيب, continue in the revascularization strategy. We speak about primary and secondary PCI, and we have a fibrinolysis. زي ما قلنا, this is in patient. We cannot do a PCI for the patient. We are in rural area. We don't have a PCI centers. We don't have يعني a cardiac surgeon who can do that. المهم, within 2 hours we cannot do a PCI, and the patient is coming early after less than 12 hours from starting his symptoms. We can do a fibrinolysis for this patient as alternative, and we have to do it as soon as possible within 30 minutes from the hospital arrival or first contact to the center. And we can use a fibrinolysis or thrombolysis drugs, which can break down the platelet, and this is known as PLACE في النهاية, اللي هو زي tenecteplase, alteplase, retaplase, and streptokinase. We give them likely in 1 or 2 bullets or as infusion in half of hour or 1 hour, and it is effective drugs. The main problem with this drug is a high incidence of the emergency of the hemorrhage, especially the intracranial hemorrhage. So we do a benefit against risk. If the patient has a high suspicion for the hemorrhage, or the patient is coming very late, so already the muscle of the heart is dying, we don't do the risk will be outweighs the benefit, so we don't give the drugs. If the patient is coming early before this 12 hours after the consultation of the cardiologist, we can give the drug for this patient. After we do that, we have to re-evaluate the patient for revascularization. بعد ما نعمل له نشوف the symptoms of the disease is relief and the ACG change. If it is يعني success, or even if it is failed, we transfer the patient to the PCI center. زي ما قلنا, most likely all patient need again to do PCI and stent for the patient. Type, when we don't give this drug, the absolute contraindication to use this drug if the patient has a cranial hemorrhage or cranial problem or tumors recently, so it is absolute contraindication. Also, if the patient has a high susceptibility to the bleeding, whatever the cause. Also, it could be absolute contraindication. In general, the absolute contraindication when the patient has a high incidence to bleed intracranial or to bleed after using of this drug for the vital organ. This is يعني, named as active bleeding. Now there is active bleeding or recent intracranial hemorrhage, ischemic stroke within 3 months, or trauma for the brain also within 3 months, and severe hypertension, which is not controlled by the emergency drugs. And if the patient has a suspicion for aortic dissection or has aortic dissection, or the patient has a bleeding diathesis عنده أمراض بتاعت bleeding like hemophilia or like that, um, DIC, and like these drugs, this disease, and the patient with intracranial tumors. This is absolute contraindication. We can't to give the patient the drug even if it is indicated to use the drug. If we need or if we use streptokinase, also we have to use streptokinase, avoid the use of streptokinase within 6 months. We know that streptokinase is coming from streptococci, which no, yani, regard as antigen for the body. In most of patients, the body start to develop antibody, and this antibody could appear for years, like with a high percent for 6 months. So if we give a patient streptokinase and the patient develop a myocardial infarction, and we need to give again, we have to avoid the use of the drug with the 6 months, because the antibody is with a high percent and will attack the drug and cause anaphylactic and hypersensitivity problem for the patient, may increase the risk of dying of the patient. The relative contraindication in relative, so we can use the drug like with a caution. Even the patient has one of these problem, major surgery, traumatic CPR, recently GI bleeding, oral anticoagulant, pregnancy, poorly controlled hypertension, or prolonged CPR for the patient. This we can use the drug even the patient has one of these, like with caution. But this is the main treatment if the patient has STEMI, اللي هو revascularization for the patient with the PCIs, which is preferable, or with a thrombolysis drugs, which could be a second line for a patient. We cannot do PCI for them. Then for all patients who are coming with STEMI, we have used adjunctive medical therapy, which is prevent the progression and decrease the mortality of the patient. We use for the patient antiplatelet therapy, and here we use a dual therapy for the patient. In stable ischemic heart disease, as we said, we use just aspirin, and if there is a problem with aspirin, we can use clopidogrel here from the start, and it's not recommended to use a dual therapy, and there is no benefit. Here from the start, we use a dual therapy for the patient. Both drugs should be used, aspirin and clopidogrel, in PCIs, and we can also use in PCIs the prasugrel and ticagrelor with aspirin, or we can use clopidogrel. For fibrinolysis, yani if the patient is going to the fibrinolysis, we use a clopidogrel and aspirin together. Also with this aspirin and clopidogrel, we use anticoagulant. Del طبعا antiplatelet. We have a drugs which is known anticoagulant, which is affecting the coagulation cascade and prevent the fibrin effect, prevent the formation of the fibrin. We can use one of these drugs like the heparin, whenever the heparin is available and there is no contraindication, we use unfractionated heparin or other like the direct thrombin inhibitors وكده. وعندنا واحد which is antiplatelet اللي هو in red color. الانتي بليتلت ده اللي هو اسمه glycoprotein inhibitors. Glycoprotein inhibitors زي الابيسيكساماب. This just used in a specific case. It should be used by the consultation of the cardiologist and could be used before the PCI immediately. This is يعني antibody drug which is block a glycoprotein receptors of the fibrin in platelet. وعشان كده قاعدين regard the drug as antiplatelet لأنه blocks the receptor in platelet. لكن also as a result it prevents the fibrin effect وبالتالي برضه ممكن نعتبره as anticoagulant in some reference. المهم this drug is used when the PCI is indicated. يعني لو عايزين نعمل للpatient PCI and it is used before PCI on or off depend on consultation of the cardiologist. The fibrinolysis, if the patient is going to fibrinolysis, we can use a heparin different type اللي هو low molecular weight inexoprine أو unfractionated heparin standard heparin أو ممكن نستخدم factor 10 inhibitors. All of them are anticoagulant زي الفوندابيرينوكس. Also, for all patients, we have to use the other adjunctive therapy, which is oxygen, nitroglycerin, morphine if needed, and high-intensity statins and beta blockers and ACIs for all patients. دي بنسميها منبش بعدين هنجيها إن شاء الله. طيب. After we do that for the patient, give all these drugs together for all patients. And then we have to monitor the patient and give a supportive care. The patient with STEMI should be treated in CCU or ICU, and we have to do a continuous telemetry. اللي هو التليمتري دي to detect the vital signs by recording الأجهزة اللي بتقيس لنا vital signs with oxygen, with pulse rate, respiratory rate. So we have to do a telemetry for the patient, a serial ECG, and troponin every 4 to 6 hours for all patients. Right. This is the main management for the patient with STEMI. يعني rarely we can use which is known as CABG for the patient, which is coronary artery bypass grafting. And here we graft a blood vessels instead of block these coronary blocked blood vessels. We give blood vessels from the body itself and insert it in يعني we take the blocked coronary artery or اللي هو diseased coronary artery and we insert or graft for the new blood vessels. لكن طبعا it's open heart surgery. We open the chest and we do the surgery directly, not like the PCIs. So it is a very invasive operation. We can do it if it is indicated, and it could be indicated if we cannot do the PCI for the patient لأنه البيشنت عنده a poor anatomy for the PCI. So the patient has anomalies, has a problem that we can't do the PCI proper. So we can do it. Or we do the PCI and it is failed to treat the problem. Or if we are already doing an operation for the patient to fix a mechanical defect in heart, and we already open the heart and the patient has the problem or develops this STEMI during the operation. So also we do the CAP. In general, it is could be يعني for a refractory case and as a third or fourth line. طيب here the management of STEMI heart disease or STEMI patient, and even the details which is discussed is very clear here Also, this is the ECG change for STEMI when the ST elevation appear, when it is disappear, and how long it take, and it could be very interesting and beneficial for your study. But the last slide will be about the less serious but still a serious case, which is could be impending to myocardial infarction, which is non-ST elevation acute coronary syndrome. Firstly, we start by if we have a patient highly suspected to ST or myocardial infarction and we don't find an ECG change, the first step is to evaluate the risk stratification, and we do initial assessment. If the patient has a high risk, so we have to follow the STEMI protocol. We regard the patient as STEMI, and we treat the patient like that, and we have to do an urgent coronary angiography within 2 hours if the patient has a very high risk or highly susceptible to develop. So we regard the patient as STEMI. But we don't do here fibrinolysis or fibrinolytics or thrombolytic treatment. So if the patient is non-STEMI, so the fibrinolysis is not indicated. Whatever the situation, we don't do a fibrinolysis. The only option could be like the STEMI is the PCIs for the patient. طيب. Also we give the patient adjuvant therapy. يعني البيشنت لو جانا ب non-STEMI, we have to start the adjuvant therapy immediately, and if the patient high risk, we have to do PCI. If not, so we continue with this adjuvant therapy for the patient and monitoring. What adjuvant therapies look like the STEMI? We use a dual therapy, antiplatelet aspirin with clopidogrel or ticagrelor or أي واحد من الجريل اللي هم ال ADB receptors blockers as antiplatelet. Also, we use anticoagulant immediately start as soon as possible, and we continue up to the end of hospitalization of the patient, or if the patient is going to the PCI, up to the PCI, we can use any one of the anticoagulant which is mentioned. And the most important point here, just bivalirudin, just use in invasive case. So we don't recommend it bivalirudin for all patients, just for a special case. Also, the glycoprotein inhibitors, abiciximab, as we said before, we just use this drug for a patient who are going to the PCIs after the consultation of the cardiologist on and off for the patient going to the PCIs. Also, we have to use adjunct therapy. Other adjunct therapy زي ما قلنا oxygen, nitroglycerin اللي هم النيتريتس, morphine and statins, beta blockers and acid E inhibitors. We call them, all of them, we call them as Munabash. M for morphine, O for oxygen, and M for nitrates, A for aspirin, BASH, B for beta blockers, A for ACE inhibitors, S for statins, and H for heparin. So all patients with acute coronary syndrome, we have to use this drug. If the patient is STEMI or non-STEMI, we have to use all these adjunctive therapy for the patient. And the last thing is to monitor the patient, continuous also telemetry for the patient and serial ECG and troponins 3 to 6 hours, and to transfer the patient to the uh, ICU if needed, if the patient is يعني progression to ischemic myocardial infarction, or the progression of the patient need ICU. That is all, and thank you for your listening. طيب, any question?
دكتور عندي سؤال.
Yes.
بالنسبة يعني إيش معنى البي سي آي، يعني إيش هي؟
اللي هي دي percutaneous coronary intervention. I have a short video. Inshallah, I will send you a short video about acute coronary syndrome and the management of acute coronary syndrome. 3 minutes video. فيه summary for all this lecture and how we deal or treat the patient in hospital. And in this video there is a PCI video. هتشوف ال PCI كيف, and it will be very clear for you. It is a surgery, لكن less invasive surgery. They going to the heart through the veins from the side of the patient veins. بيدخلوا بwire till they are reaching the area of the clot. They take or remove the clot, and they put a stent to prevent the recurrence of the clot here, and they are going back, يعني بيطلعوا بعد ذاك. And this is a PCI, اسمها percutaneous coronary intervention. وعندي زي ما قلت لك الفيديو هتكون very clear فيهم.